India, Endocrine Society, West Bengal, Honorary Joint Society of Secretary of IDEA, and currently he is working as a senior consultant endocrinologist in Apollo Gleneagles Hospital and an adjunct associate professor in the Department of Diabetes and Endocrinology, Apollo Gleneagles Hospital, Kolkata, India. I just shared the poll results. There has been 5 takers for, well, majority. I would say 80% have voted for A and 20% for C. Subir, over to you for the 80% for A and 20% for C.
Right. Okay. Thank you very much, Shomo. Am I audible?
Yes, you're audible, please.
Right. Okay. Can I share my screen? Right. Thank you very much, Shomo, for your kind introduction, and thank you very much, Deblina, to present such a fantastic case. It gives us, one certain message that a thorough knowledge in endocrinology and parallel thinking can clinch even the rarest of the rare cases in resource-restricted setups as well. And if I look at the poll result, it tells us that even innocuous problems like hypothyroidism management is not as innocuous, or kind of in Shomo's language, fill it, shut it and forget it kind of thing. I mean, even in this scenario, there is no unanimous choice. There is a 50-50 split. So I guess this talk needs to be given. Okay, rather than going to the different clinical scenarios straight away, which Anirban has requested me, I'd rather give you the understanding of the problem so that you can make up your mind when to go up, when to go down, and when to stay where you've been as far as levothyroxine doses are concerned. So that's my agenda. I'll just talk about the thyroid hormones and levothyroxine therapy in general, in very brief, of course. I'll tell about the initial dosing, how you decide how much to start with, and how to adjust the subsequent dosing. I'll tell you the different situations where levothyroxine dose needs to be adjusted in different phases of life, different clinical situations, and some medical conditions and medications which necessitate this dose adjustment. So if you look at this levothyroxine, which is a synthetic T4 hormones, which is biochemically and physiologically indistinguishable from the natural one, we use levothyroxine for 2 simple purposes: either to replace a thyroid hormone which is not coming out of the thyroid gland, which is there but underactive, or which is not there, taken out, or to use as a suppressive therapy when we do not want any thyroid activity in the body to go on. And we monitor every 6 to 8 weekly with TSH, T4, if possible, free T4, and occasionally T3, which is not always required. If you look at the levothyroxine therapy, we all probably know that orally administered levothyroxine therapy is very well accepted therapy. We hardly use any other mode of use. It's 80% intestinal absorption. So even if you give it through a tube crushed in a little bit of water, the job is kind of done. It's absorbed better in a fasted state rather than fed state. The minimum gap between levothyroxine therapy and the other foods and drugs that may interfere with the absorption is ideally 4 hours, but even an hour to 1 hour gap is good enough. And after taking the thyroid tablet, it takes around 2 to 4 hours for the peak to develop. So if you check free thyroid hormone 2 hours after taking the tablet, you might get slight erroneous high peak, which can be avoided if the blood is given within 2 hours after taking the thyroid tablets. So these are the tips of checking and monitoring and giving thyroid tablet. Okay. These are the factors that can influence the absorption and bioavailability of thyroid tablets. So you can identify the areas where you have to, educate your patient so that the patient doesn't get the fluctuation, and you do not have to, switch the dose up and down every now and then. So thyroxine, levothyroxine is mainly absorbed specifically through the duodenum. So somebody with a short, a small intestine, like after bowel resection, will have reduced absorption and require higher levothyroxine doses. Very simple. It doesn't need to be a rocket scientist to understand. Okay, again, the bioavailability of thyroid hormone, thyroid levothyroxine therapy is reduced in the presence of food and drugs like iron, calcium, aluminum hydroxide, cholestyramine, cholesterol, sucralfate, multivitamin, this and that. So we have to tell the patient not to take all those things within an hour or two of taking the thyroid tablet. Okay, absorption of levothyroxine appears to be influenced by the gastric pH, and reduction of the gastric pH by the use of PPI is associated with increased dose requirement because of lack of absorption. So it is not that you have to tell the patient that you take your omeprazole tablet or lansoprazole tablet 2 hours later, but you have to discourage the patients from taking unnecessary PPI, which will reduce the gastric pH and hamper that absorption. Okay, all Bengalis are basically taking PPI, so you have to discourage them from that habit. Okay, coming to the pharmacokinetics of levothyroxine, the main metabolic route is basically iodination, the removal of the outer iodine ring. It makes T4 to T3. So basically, you can call T4 a prohormone for T3. The inner ring deiodination can cause formation of the reverse T3, which is biologically inactive. So any medication or any phenomena that can cause increased hepatic metabolism, like the concurrent of barbitone, phenytoin, carbamazepine, rifampicin, multi-kinase inhibitors like imatinib, axitinib, solitinib, vantinib, they can all cause the problem of T3-R-T3 ratio and cause reduced requirement of the levothyroxine dose. So these are the medication when the patient is getting, have to be careful about monitoring the TSH and hike up the dose if necessary. Coming to other conditions where you get the different absorption or different availability of the free hormones, like protein binding. This is one of the problems we frequently face, and I'll discuss it in slightly detail a short while. Both T4 and T3 are highly bound to plasma proteins and very, very high bound. So you can see that the unbound T4 is 0.02 to 0.03%, and unbound T3 is 0.2%. So any condition, okay, any condition where you get increased thyroid binding globulin or thyroid binding prealbumin or albumin, like what we get in pregnancy, or if a patient is getting estrogen therapy, you can expect there is less availability of the free hormones. So the patient needs more thyroid supplementation to suppress or keep the TSH in the target range. So how do we decide about the initial dosing, and what are the factors that we need to think about so that we don't have to change the dose so often? So a slight clever or smart calculation and thinking will help you a long way. The levothyroxine dose initially, the initial dose requirement depends on three major factors. One, the residual thyroid function. So if somebody doesn't have the thyroid, and if somebody has got half the thyroid, will require probably different kind of dose to start with. The body of the patient, or the lean body mass of the patient, heavier the patient, more will be the requirement, and the target TSH, whether you would like to keep the TSH in the lower end or in the suppressed range, or in the higher end, the normal, according to other factors like the age of the patient, the gender of the patient, whether the patient is in pregnant state or not, whether the patient has got concomitant other comorbidities like cardiovascular problems, severe anemia, etc., and whether the patient getting any other treatments like the medicines I've just mentioned earlier. Okay, and you have to get the test done, at least the TSH test done from a reliable laboratory where they do sensitive TSH measurement, because that's what you'll be depending on. So these are the suggested starting dose, which I also normally follow. In a normal, otherwise normal patient is a 1.6 microgram per kg per day. So if somebody is say 60 kilo, the requirement would probably be 100 microgram per day. If somebody is say around 70 kilo, the requirement would be anywhere around 125. So that's the starting dose. If the patient is otherwise normal, there's no point starting with half the dose. So you can always start with full dose. In elderly patient, you have to be careful because it might trigger cardiac arrhythmia. So quarter the required dose, like 25 mcg or 50 mcg is a reasonable start. Okay, if somebody has got ischemic heart disease, I would rather start even lower, like 12.5 or 25, unless the ischemic problem has been taken care of, like the patient has already been bypassed or stented. Coming to other some clinical important pointers. When you do thyroxine therapy, you have to keep few things in mind. So don't be fidgety. You'll get the T4 changes earliest, then you'll get TSH changes after only 6 to 8 weeks of therapy, and majority of the time the patients will respond very slowly, even when the TSH is coming down to almost normal range. Many patients will not tell you that they are feeling 100% better. So you have to be careful not increasing or decreasing that dose too early, and allow the medicine to work for some time before you can take a call about the dose changing. Okay. These are the other important clinical pointers when you monitor the thyroid the levothyroxine doses. You have to know whether you are treating a patient or looking at a patient with primary hypothyroidism or secondary or central hypothyroidism. When you're treating a patient with primary hypothyroidism, TSH is your marker. When you're treating a secondary or central hypothyroidism, look at free T4 and T3, not TSH, because you'll be getting a very suppressed or undetectable TSH. So you try to keep the free hormone levels in the upper range of normal and mid-normal range rather than looking at the TSH. Okay, this is one clinical scenario where you have to be very smart. The persistently elevated TSH, which defies all kind of logic, and believe me, the commonest and probably the only cause is poor compliance, because the tissue level unresponsive to the thyroid hormone is extremely rare. So in the UK, which we used to do many a times, is to give supervised therapy. Many times you'll see the T4 level is almost in the normal range, but the TSH is very high. That means the patient was not has just started taking the dosage because it reminded that she will be or he will be coming to your clinic. Okay. Coming to the other very common situation, like pregnancy, you'll see there is dramatic increase in the requirement of the levothyroxine doses during pregnancy. It is mostly it is caused by increased thyroxine binding globulin concentration, the TBG concentration, and of course increased plasma volume. You'll see that not all your patients are requiring the similar kind of excess thyroid dose requirement. Around 30 to 50% of the dose needs to be hiked up in around 50 to 85% of the patient, but some of the patients will probably not require it. Ideally, what happens? Not ideally. Usually, what happens that you need to hike up the dose pretty quickly in the first trimester, then it tends to plateau, and you tend to cut down the dose a little bit in the third trimester. Okay, that's how it behaves normally. Okay, and what is a common sense is, if you do not want to change the thyroid hormone dose too often, the patient cannot fully come back to you to your clinic that often, try to start the pregnancy with a low slight lower in the normal range TSH, so that you do not have to change the dose or increase the dose very, very frequently. Aging is another problem where you have to be careful to protect your patient. Majority of the patient, they require less thyroid hormone supplementation because the target TSH is on the higher side. There are quite a few explanation why it happens. Probably there's a decline in the thyroid hormone binding proteins. Some medications, and Devlina's case is a classic example of medication causing increased requirement of levothyroxine doses because estrogen therapy can cause increased TBG, and the free hormone requirement, free hormone level is gone down. So you have to hike up the dose to keep the TSH in the target range. As another example, you can see here a patient with hypothyroidism who started with kinase inhibitors for renal cell carcinoma. The TSH, which was normal earlier, slightly suddenly skyrocketed. Of course, the explanation is tyrosine kinase inhibitors. They kind of accelerate the conversion of T3 to reverse T3, which is inactive. So the patient requires more LT4 supplementation to keep the TSH in the target range. Supplementation of food, another example. It's a funny example. The patient who had otherwise very well stable thyroid status joined a new job, and then TSH went up, and on inquiry she told that she has started taking soya milk in the morning before she goes off to the office, and she takes her thyroid tablet along with soya milk, and that has kind of decreased absorption of thyroid hormones. So this patient was advised not to take thyroid hormone in the morning because she would love to have the soya milk. So you cannot negotiate with that. So you give the thyroid hormone in the before bedtime when the stomach is slightly empty, and it kind of did the trick. Some medical conditions where you have to be careful what you're looking at, like this patient who's a differentiated thyroid cancer patient, been discharged from the follow-up from the cancer hospital because she had this done 15 years ago, an uneventful follow-up. And she's still taking the suppressive dose of thyroid hormone. She has developed congestive failure, osteoporosis, TSH is suppressed. So what you need to do is you need to understand whether this patient needs to be on suppressive dose any further or not. If not, cut down the dose, bring the TSH to normal for that particular person, and allow the person to feel better and to prevent further osteoporosis and heart failure. At the same time, I've seen many patients who just a couple of years into their follow-up for thyroid cancer under suppressive therapy, and the general physician has seen that TSH is all being suppressed, cut down the thyroxine dose from 200 to 100, and TSH went up, and kind of irritated both myself and the oncologist. So we have to be careful about this thyroid cancer patient. You have to know what kind of therapy they actually require, and what should be their thyroid TSH target. Okay. Renal impaired patients, again, you probably need to hike up the dose a little bit because of several reasons. There is reduced peripheral metabolism. There is hemodilation because of the water retention. So most of the majority of the patient might require a little bit of adjustment. Kidney transplantation doesn't have much to do with thyroid replacement dose changing. Hemodialysis doesn't have much impact on LT4 requirement. So there's a few areas in renally impaired patient you have to think about. In hepatic impairment, there may be increased dose requirement because of in surgical jaundice there is defect in the bile production, so there is defect in the absorption of levothyroxine. There could be increased binding of LT4 because of the increased TBG level, because chronic liver disease, there is hyperglobulinemia. So in those situations you have to kind of increase the dose, but monitoring is probably the best. Another very funny thing, seasonal and diurnal variation of TSH serum levels. It doesn't happen in euthyroid patient. Okay, it happens in somebody who's abnormal thyroid function, that is athyrotic patient. Either the patient has got abnormal thyroid function, underactive thyroid function, or reserved thyroid function, or deranged thyroid function, or the patient doesn't have the thyroid, like in a post-op patient. Okay, it happens that the patient requires more thyroid replacement in the winter and less in the summer. Similarly, there is no clear-cut answer to this. I'll give you my take. Similarly, there is a slight diurnal variation which does not happen in euthyroid patient, but may happen in some of the hypothyroid patient, that TSH is lowest if you do it in between, say, 11 o'clock to 4 o'clock, and it is lowest if you so it is highest if you do it in the morning or in the middle of the night. Okay, my explanation is that it is a simple mechanism of the body protecting itself. So in summer, the body doesn't want too much of replacement, so natural TSH goes down. In winter, we want the ambient temperature to be comfortable. If not, we have to increase our own body temperature to feel comfortable, so we need slightly more supplementation. Similarly, in the daytime, at least in the tropical country, when the heat ambient temperature is very high, body wants to cool down and doesn't want too much of thyroid activity, so it doesn't require so much of thyroxine replacement. So that's my understanding about the whole issue, but the exact mechanism is not known. So if I have to give you a take-home message about this levothyroxine therapy, and when to go up and when to go down, just be smart and just use your common sense. You calculate the initial dose carefully. You monitor every 6 to 8 hours hourly till stable. Be patient, but be watchful. Don't be hasty. Don't just get pushed around and start checking thyroid function every second week. Okay. Be aware of the clinical conditions and the medications that patients are taking. So it is not exactly fill it, shut it, forget it kind of thing. You have to be careful. You have to be watching the patient carefully. Significant seasonal variation of TSH may occur in some patients and catch you off guard. You have to check compliance in weight matched dose and TSH mismatch. Like you have given the dose which is required, but the patient is not responding as far as TSH is concerned. And of course, you have to know whether the patient is on suppression therapy or replacement therapy when you look at TSH to be less than say 0.01 or suppressed. Okay, that is what I had to say today. Thank you very much for listening.